Hi, my name is Armonde Baghdanian. I'm a radiology resident currently at Boston University Medical Center, and I've completed 4 years of undergraduate training at UCLA. I worked a year as an emergency medical technician on an ambulance, followed by 4 years of med school, a year of internship in internal medicine, and currently my radiology residency, where I'm in my third out of fourth year of training. This will be followed up with a fellowship in abdominal imaging at University of California, San Francisco, where I'll deal with both cancer and other patients with disease related to the abdominal pelvic cavity. For me, as a radiology resident, we deal mostly with cancer patients during our PET-CT rotation, where we use molecular imaging for the staging of cancer, for primary diagnosis sometimes, and for restaging to see if patients that are thought to be in remission possibly have disease recurrence. However, the troubling thing I find is when cancer patients present to an emergency department, and out of the emergency department, the incorrect diagnostic examinations are ordered, which are inappropriate at that time, are not necessarily emergent, and should not be performed in actuality, unless they pertain to the patient's acute presenting symptom, in which case the exam is not a survey or related to the cancer diagnosis itself. And the trouble I find is that, first of all, patients can be presenting to the emergency department somewhere where they're not usually being treated. They may not know even of their cancer diagnosis, even though they have been worked up, and undergo unnecessary procedures and examinations, or undergo unnecessary harm. Also, the follow-up of cancer patients has become so complex that it's a multimodality approach, usually involving a tumor board composed of several different specialties that give the best possible care to patients. And therefore, from an emergency department, a patient should not have specific imaging examinations ordered for the workup of their cancer diagnosis. They should be performed after the patient after all information or medical information is known about the patient, and their acute symptoms are treated and diagnosed accordingly. When a patient presents and the admitting team or the ER clinician decides to further work up their cancer diagnosis, frequently they may have unnecessary examinations, unnecessary radiation. They may be admitted and have unnecessary procedures or biopsies for a condition they already have. And overall, it can have unnecessary psychological concern and stress. And in addition, they can be followed up with an entirely different team with a different plan than their original provider. Therefore, I feel like we need to come up with a way to, or have guidelines where cancer patients that present to emergency departments, we know which imaging examinations are appropriate in the acute setting and which should wait, so that patients have the most appropriate examination related to their primary cancer diagnosis, instead of having unnecessary examinations, procedures, and undue stress or harm. Thank you. My name is Armonde Baghdanian from Boston University Medical Radiology, also known as the BOMC Trauma Group.